So good afternoon, everyone. My name is Teresa Brockie. I am Ani from Fort Belmont Reservation in Montana and an assistant professor at Johns Hopkins School of Nursing. I serve as co-chair for this planning committee. Thank you for your attendance. Today I will provide an overview of our work with the Fort Peck Sioux and Assiniboine tribes, focusing on our RCT, Wakanyazi, or Little Holy One. Next slide, please. Our project is supported by funding from the National Institutes of Mental Health and EKC Foundation. Next slide, please. So we have a 10-year collaborative partnership with the Sioux and Assiniboine tribes. I came in and did my dissertation research in 2011, a little less than a year after Fort Peck experienced a suicide cluster. Our tribal advisory board and key stakeholders are consulted on a regular basis in our work, and they helped develop a logic model to address stress and trauma symptoms, which guides our work. All project phases have employed community-based participatory research approach. Next slide, please. And this is the 10-year span of the work at Fort Peck. Again, in 2010, Fort Peck declared a state of emergency after a suicide cluster occurred among youth, primarily among youth. We came in 2011 and conducted a study on the risk and protective factors for youth suicide. And over the years, we've done a lot of work in the community. 2019, we were funding for our Little Holy One study. And I just want to say our 2020 studies include a PhD student who's coming behind and that has adapted our cultural lessons for our study. So it takes a long time to make any progress, but it also takes commitment. And we have to be committed to working with communities over the long haul to have any impact. Next slide, please. So this baseline study is a historical trauma, contemporary trauma-related factor study. We looked at multiple factors among 288 adolescent and young adult Sioux and Assiniboine members. And we found that historical trauma, as we operationalized it, was associated with suicide ideation and attempts. Communal mastery or group efficacy, tribal identity, and attachment to education was protected against high-risk substance use and suicide risk. Community members were consulted to determine next steps in addressing issues of substance use and suicide. Next slide, please. So this is kind of what guides I have to remind myself of the prevalence of suicide across the Indian Health Service areas. And so among the subgroup of Native Americans that receive their health care through Indian Health Service, there is a tenfold difference in suicide rates, and this is a visual of that, across the 12 geographical areas. From this figure, we can see that suicide has more to do with place rather than race, and that factors that drive health inequity are systematic and not distributed randomly. Also, that social determinants of health are unequally distributed. Next slide, please. As I said, our suicide study provided the data, the baseline data for developing interventions. Once we had the data collected from the suicide study, we met with our tribal advisory board and reported to the tribal leadership. Our tribal advisory board directed us on our next phase of our work, and this is the result of that work. Wakanyazi is the Dakota word for child that translates in English to Little Holy One. Next slide, please. Just a minute. Our study was informed again by the findings from the dissertation. The Fort Peck Reservation, again, as Larry mentioned earlier, is one of 7 in the state of Montana and was established by the Fort Laramie Treaty in 1855. It is extremely remote with a population density of 5 people per square mile, significantly less than the US average of 90 people per square mile. There are no services for inpatient psychiatric care. Any acute psychiatric needs are addressed in state up to 460 miles one way from Poplar, or out of state, about 200 miles from Poplar at Trinity Hospital in Minot, North Dakota. Adolescent psychiatric needs are addressed in Billings, Helena, or Minot. Long-term psychiatric patients are referred to the Montana State Hospital in Warm Springs, 500 miles away from Poplar. Next slide, please. So our participants include Fort Peck's Assiniboine and Sioux parents who have experienced at least one adverse childhood experience or historical trauma, and their children, 3 to 5 years old, either enrolled in Head Start or not. Parent-child dyads are randomized 1-to-1 to Little Hole 1 or the control group that consists of 12 lessons taught by Indigenous community health workers. Next slide, please. Our study goal is to increase protective factors and decrease risk factors related to youth suicide and substance use, starting early in life. The intervention combines adapted elements of Common Elements Treatment Approach, or CETA, an evidence-based intervention proven to reduce stress and trauma-related symptoms, and 2, a family spirit and evidence-based parent intervention proven to promote positive early childhood development, and 3, newly created cultural lessons designed to promote tribal identity, communal mastery, smudging, and address historical and contemporary trauma. Next slide, please. We included evidence-based lessons from CETA and Family Spirit and developed content for 4 cultural lessons based upon prior findings. Using a randomized control trial with an embedded single-case experimental design will allow us to determine the added impact of unique cultural components. Next slide, please. These are the 12 lessons that comprise Little Holy One. From Family Spirit, our lessons adapted from that include encouraging early learning, daily routines, monitoring your toddler's routine, skills for effective parenting, and from CETA, learning about emotional and mental health, cognitive coping skills, substance use, trauma narrative, and our cultural components are on promoting positive tribal identity, promoting smudging, enhancing communal mastery, healing historical and contemporary trauma. Next slide, please. So focusing on the cultural lessons. So enhancing tribal identity, traditional naming, as an example, connects one with the creator and the responsibility to live a good life by understanding and walking on a spiritual path. Promoting smudging promotes therapeutic healing. It's a therapeutic healing practice used to resolve unsettling thoughts and feelings, and it's used in ceremony and daily prayer and meditation. Communal mastery, the making of relatives, and the moccasin telegraph activities will help participants understand their sacred relationship to others, their roles, responsibilities, and the therapeutic value of connectedness. Healing historical trauma, the wiping of the tear ceremony, and storytelling narrative for healing will be used to address historical and contemporary traumas. Next slide, please. So our expected outcomes The curriculum is designed to be strength-based and holistic, promoting family wellness across mental, physical, emotional, and spiritual domains, represented as balanced quadrants in the Native American medicine wheel. Slide 15. Next slide, please. So this is a more detailed visual of the short, medium, and long-term outcomes. Elements of CETA will be applied to reduce parent stress and trauma-related symptoms. Elements of family spirit will be applied to improve parenting, and the cultural components will promote tribal-specific protective factors while buffering the effects of historical trauma. Next slide, please. For study design, we're utilizing an innovative trial design which allows for better understanding of the impact of cultural lessons, including positive tribal identity and communal mastery. Next slide, please. So if we looked at the figure on the right, parent-child dyads, 120 parent-child dyads will be first randomized to Little Holy One or the active control. And then after the second lesson, we can see on the right, on the left, after the second lesson, participants will be randomized to immediately receive a smudging lesson in session 3 or wait until session 5 to receive the smudging lesson. And after the 6th session, participants will either immediately receive the communal mastery lessons in session 7 or wait until session 9 to receive the communal mastery lesson. So they're randomized 2 more times through the SCID. Our first order randomization to either Little Holy One or the active control is aimed at understanding intervention effectiveness, while a second order randomization aims to understand the impact of specific cultural components, and that's the smudging or communal mastery lessons by controlling for time participating in the intervention. Embedding the SCID in a randomized controlled trial will allow for understanding how specific cultural components may provide immediate benefit and can inform future adaptation. Slide 18, please. Next slide, please. This is our control group will receive an optional 30 to 60-minute nutritional session every other week for 12 weeks. Sessions will be attended by children and their parent/caregiver. 2 modules from Healthy Youth Control curriculum have been adapted to create six lessons. Next slide, please. So study results will provide insights about the potential of a culturally based intervention to reduce parental distress, an upstream approach to reducing risk for children's later substance misuse and suicidality. Intervention design features including use of community health workers, culturally grounding and administration in Head Start settings, blend potential for feasibility, acceptability, sustainability, and scalability. And I believe I am finished. Next slide, please. Guinea Hayats for your time and attention.